My name is Daphne Moutsoglou, and I'm a gastroenterology fellow at the University of Minnesota, and I'll be presenting our research. Encapsulated microbiota transplant therapy improves partial Mayo scores in ulcerative colitis and induces rapid engraftment compared to placebo control. And I don't have anything to disclose. I wanted to start by highlighting the major findings of our trial using oral lyophilized microbiota transplant therapy versus placebo control in patients with ulcerative colitis. Patients received oral lyophilized microbiota transplant therapy, which is a standardized GMP product of fecal microbiota transplant material that was produced with funding from Achieving Cures Together. We found that this treatment induced significant engraftment in patients with ulcerative colitis, which was our primary endpoint, and also reduced partial Mayo scores, and this was achieved without any antibiotic preconditioning. So why should we study microbiota transplant therapy as a treatment for ulcerative colitis? Ulcerative colitis is a complex disease that's likely multifactorial. However, it's thought that indigenous microbiota trigger an inflammatory response. The mainstay of treatment is to reduce this response, and though treatment with biologics and immunomodulators are effective, there's evidence that we're hitting a therapeutic ceiling. Therefore, trying to reverse the altered microbiome has been a goal of many studies, including several randomized control trials, which have shown a possible role for fecal microbiota transplant therapy, or microbiota transplant therapy as we like to call it, as a treatment for ulcerative colitis. However, this has typically been given through different delivery methods, and the amount of microbiota have not been standardized. We found that the number of bacteria in a given amount of stool can significantly differ donor to donor, or even within the same donor at different donation times. In our trial, we've developed a standardized way to give microbiota transplant with a standardized dose, as well as ensuring the viability of bacteria in each treatment. The major goal and primary endpoint of our trial was engraftment of donor microbiota. Microbiota transplant therapy was produced at the Microbiota Therapeutics program at the University of Minnesota, which was founded by Dr. Koritz. And again, funding for making these capsules was provided by Achieving Cures Together. Our drug name is MTP-101C, and it's considered by the FDA to be a live biotherapeutic product. We enrolled 27 patients total, 13 in the microbiota transplant therapy arm and 14 in the placebo arm. And these patients in the microbiota transplant therapy arm received 200 billion bacterial cells in 2 capsules given every single day for 8 weeks. Our trial was a double-blinded, randomized 1-to-1 placebo-controlled trial in which patients received 8 weeks of daily encapsulated lyophilized microbiota or placebo capsules, followed by 4 weeks without any dosing. Stool was collected every single week for 12 weeks total, and partial Mayo scores were collected every 4 weeks. Our inclusion criteria included patients aged 18 to 89 years. They had to be diagnosed with ulcerative colitis, both clinically and pathologically, and they had to hold this diagnosis for greater than 3 months. They also had to be on a stable medical regimen to treat their ulcerative colitis for at least 4 weeks. And they had to have active disease on endoscopy with an EMAO subscore of greater than or equal to 1. They also were not allowed to use any antibiotics or probiotics within the previous 30 days. The goal of our study was that patients had to have active endoscopic disease, but also be on stable maintenance therapy. And there were no symptom criteria to enter our study as it was exploratory. The goal of our study was to assess engraftment in the setting of active ulcerative colitis. And so patients were randomized based on treatment to either the microbiota transplant therapy arm or the placebo arm. And we investigated baseline demographics between the 2 groups. And by chance, none of the baseline demographics that were measured differed in significance between the 2 groups. So there were no significant differences between the MTT arm and the placebo arm based on median age, sex, race, the duration of their ulcerative colitis disease, whether or not they were naive to biologic or advanced therapy, whether or not they had been on current advanced ulcerative colitis therapy, and whether or not these patients were on oral steroids. We also investigated whether there were any differences in baseline partial Mayo scores and endoscopic severity. And while there were no significant differences in partial Mayo scores at baseline, the patients in the MTT group tended to have more moderate to severe symptoms of their ulcerative colitis. However, when we investigated broadly between our two groups based on the partial Mayo score class, based on remission, mild, moderate, or severe, there were no significant differences. And when we also looked at endoscopic severity of disease between the two groups, Mayo subscores 1 through 3, we didn't find any significant differences. Next, we investigated the effects of microbiota transplant therapy on the microbiome. And one way we can do this is by measuring diversity, which is an ecological measure of a population, and in our case, it's microbiota. And one of these measures is the Shannon Diversity Index. So Shannon Diversity Index measures how even a microbiota population is, or how evenly distributed the different taxa are, as well as richness, or how many different taxa are present. So when we investigated differences in the placebo arm versus microbiota transplant therapy arm, at all time points, weeks 0, 4, 8, and 12, there were no significant differences. And so we were surprised to see that giving our patients microbiota transplant therapy every single day for 12 weeks did not significantly increase Shannon Diversity Index. We also looked at engraftment, and this measures the proportion of donor microbiota, or how similar our patients are to their donors in terms of what their microbiome looks like. And the way that we measured this was by using the Bayesian algorithm source tracker. And so to control for our placebo group, the patients enrolled in the placebo group were given the same, we told the computer that they were given the same donors that the microbiota transplant therapy group received, and they were matched to these donors temporally in time as they were enrolled. So the source track algorithm thought that these patients had received microbiota from actual donors, even though they hadn't. So when we ran this algorithm, we found that at all time points, patients in the microbiota transplant therapy arm had significantly elevated similarity to donors at all time points during active dosing from weeks 1 to 8. But also, interestingly, at week 12, which was 4 weeks after the last dose of microbiota transplant therapy. So next, we investigated the effects of microbiota transplant therapy on partial Mayo scores. And the way that we measured this was from our patients was stool frequency above normal and the presence of blood in stools, as well as a physician global assessment of how the patients were doing. So even though we weren't powered to detect a difference in partial Mayo scores, what we found was that the patients in the microbiota transplant therapy group, seen in purple, have significantly reduced partial Mayo scores at weeks 4 and weeks 8 during active dosing compared to their baseline scores. However, at week 12, we didn't see any significant difference. And when we made this same comparison in the placebo group, as you can see in the yellow bars, we can see that during all time points, there's no significant difference in partial Mayo scores compared to baseline. We also measured clinical response in our patients, and this is a decrease in the partial Mayo score of greater than and or equal to 2. And patients also were not allowed to be on any systemic steroids. And what we found was that patients at week 4 in the microbiota transplant therapy arm, a higher proportion of them achieved a clinical response compared to the placebo group. However, when we looked at the proportion achieving clinical response at weeks 8 and weeks 12, there was no significant difference in the microbiota transplant therapy arm compared to placebo. We also found that there were no serious adverse events and no microbiota transplant therapy related adverse events. So in conclusion, we found that microbiota transplant therapy given daily for 8 weeks results in significant engraftment of donor microbiota. The patients also have reduced partial Mayo scores at weeks 4 and weeks 8, and a higher proportion of patients achieve a clinical response at week 4. And also that this treatment results in no serious adverse events. So our future directions include to perform taxonomy analysis, where we look at how the taxa change all the way from phylum down to genus. We also are planning on performing shotgun metagenomics, which gives us data on species as well as the functional capacity of these species, or what genes these bacteria have in them that may have effector functions, as well as performing metabolomics on the stool. We're also in the future very interested in finding out, can antibiotics improve engraftment, and can microbiota transplant therapy be used as an induction therapy along with biologics? And so with that, I'd like to thank our collaborators at Indiana University, our funding, which includes funding from Achieving Cures Together, our healthy stool donors, as well as our patients in the study, and everyone with the Microbiota Therapeutics program at the University of Minnesota. Thank you.